Good day. Thank God for the opportunity to be at this conference this year, though virtually. I want to congratulate the Society for Specialists in Airway Management for this third annual scientific conference. I'll be speaking on airway management in the intensive care unit. I hope to do this in the next 25 minutes to 30 minutes. These are my affiliations. I'm a professor in the University of Ibadan. I'm the president of the Intensive and Critical Care Society of Nigeria, honorary consultant with University College Hospital Ibadan, and I'm an associate, critical care associate of the Royal London Hospital. I have no disclosures. So we'll follow this outline. We'll look at the introduction, then considerations in critically ill patient when it comes to airway management. We'll look at the management proper, human factor and airway management conclusion and future research. I'll be focusing on two objectives mainly, the peculiarity of airway management in the critically ill patient and airway management techniques in the critically ill patients. As a form of introduction, let me remove this one. So as a form of introduction, management of the airway in the intensive care unit is quite common, but it's also a very complex procedure. Patients usually are the limit of their functional reserves because of underlying hypoxemia, hypotension, and many other medical issues. And so this increases the risk of complication during trachea intubation. And according to National Deep Project, the latest one, the incidence of difficult airway is much, much higher in the ICU compared to in the operating theater. In the study done by Matra et al. On airway management in critical ill, there were many factors listed that are responsible for those challenges we have in the critically ill. And this covers many areas, including ICU environmental factors, there's poor access to patient head and neck. Head usually in the ICU. There's lack of space around the patient because of ventilators and other equipment. Also, as per equipment too, in the ICU, you don't have, in most ICU, it's not like in the theater where you have all the requisite equipment you need when it comes to difficult airway. Also, monitoring, sometimes or most times the monitors are at the patient head. So for you to, when you are intubating the patient, you have to be bending, turning your neck, or you have to get an extra monitor to face you while you are managing the airway. Let's look at patient factors. Airway assessment may be difficult due to lack of time and patient being uncooperative. Most times there could be challenging at something because maybe patient has cervical spine injury, airway injuries. There can be risk of aspiration because patient may not be faster at that time you needed to intubate the patient. Okay, and let's look at operator factors. Training in terms of airway management is not like for the anesthetists. For the intensivist, they are not as vast when it comes to airway management compared to someone who is purely an anesthetist. That is why it's even an advantage to be an anesthetist and also work in the ICU. It's really an advantage. So let's go on to management proper. This has to start with the history, just like in any other condition. You want to know the history related to present illness and comorbidities, the history related to the airway management, the time of last oral intake, contraindications to use of succinylcholine and other drugs, allergies, and all sorts. You want to find out if there's any history of sleep apnea, denture, and just as you will do when you are managing the patient in the theater. Previous history of difficult airway also is important. So that means you have to review the case note of this patient before you just go ahead and approach the airway. Examination of the cardiorespiratory system and other systems also important. Though sometimes you might not have all the time, but if you have all the time, it's important you do all this. Relevant investigations and imaging reports also should be reviewed. Now let's go to the airway assessment. You need, oftentimes, full airway assessment is impracticable because of the condition of the patient. But sometimes, if the patient is receiving oxygen with via face mask, you can quickly take off the face mask and look at the face, just assess the face of the patient. Then you can make use of nasal oxygenation while trying to assess the patient. You know, maybe if you've taken off the face mask, you need to provide. So the important thing is you must not leave the patient without oxygenation. Then, if you have time to assess the airway, assess for difficult intuition, assess for difficulty with rescue techniques, and aspiration. So that means you want to check if the patient can open the mouth, assess the, look at the mouth. Malapathy while lying down in this group of patients is acceptable. And assess the neck of the patient. Sometimes, patient has, or maybe most time, sometimes they have a collar or something around the neck. So you might need to remove the collar and check the neck to be sure that when you need to do front of neck access, it won't be that difficult for you. Then find out the last time patient ate. Okay, this is also important. Now, in difficult and obtrusive patients, airway assessment might be difficult. So that means that you have a poorly assessed airway, and that might make the patient a bit difficult. The patient record is so important, as I said. Patient habitus. So the importance of looking at the case note cannot be overemphasized, please. So as I said, malapathy class is valid in supine patient with voluntary mouth opening. In the ICU, the only validated tool for airway assessment is actually the Makuka score. Okay, this has 7 components in 3 domains. A score of 3 predicts difficult intubation in the critical area. Sometimes, it's important to note because sometimes we overlook this. The degree of cardiorespiratory disturbance in the patient should be noted so that after intubation, you will know whether the patient has deteriorated or not. So this is the score, okay? Malapathy, which stands for M, apnea, A, cervical spine, C, limited mouth opening, O, coma, factors related to pathology, coma, C, severe hypoxemia, that's the H. Then the A, the last A is the whether person intubating is a non-anesthetist or anesthetist. So you can see all the points. So anything 3 and above, that patient is a potential difficulty airway patient, and they must be prepared with all the facilities for difficulty airway management. Now, in choosing the airway management technique in this patient, these factors are actually important. The airway of the patient that you have assessed, okay? Whether the patient is breathing or not breathing, okay? Because if the patient is breathing well, and maybe the assessment does not reveal any difficulty as such, but patient is breathing well, might just focus on non-invasive ventilation, okay? The hemodynamic condition of the patient also is important, and cooperation of the patient also is important. So these are a few factors that are important when choosing the airway management technique you want to employ. Now, let's look at this guide. So in this patient, you want to check if the respiratory rate is above 30, and this criteria for ventilation and oxygenation in ICU patient. Okay, vital capacity is less than 10 to 15 minutes per liter. PO2 is low, and there is high PCO2. So you need to also check if patient breathing spontaneously, is patient dynamically stable, can patient protect the airway or cooperative. If all these are right, then that patient might just need a non-invasive ventilation or non-invasive airway management. Okay, maybe a patient with asthma, or patient with hypercapnia, patient with pulmonary edema. Okay, might just be non-invasive ventilation that is needed for that patient. But if Patient is not breathing well, not dynamically stable, you might need to consider invasive airway management in that patient, okay? And you either go for intratracheal intubation or tracheostomy. If NIV fails, that patient eventually will actually go on to have intratracheal intubation. Similarly, intratracheal intubation will be successful most times, but if it fails, or if it's after a prolonged period, you might actually go on to tracheostomy for that patient. So let's look at a few indications for non-invasive airway. Hypoxemia requiring high respiratory rate, and the effort patient is having very increased respiratory effort, and the FiO2 is also low. Hypercapnia in a fatiguing patient, that patient might actually need non-invasive airway management. It can be used as a winning modality, and sometimes we want to avoid enterocardial intubation where desirable, so we can make use of the non-invasive airway. Actually, our focus today will be mainly on the tracheal intubation, so I'll go to that immediately. So the invasive management, you have the enterocardial intubation, as I said, and tracheostomy. So for tracheal intubation, this is particularly useful in high-risk patients, and it's actually a high-risk procedure. We must know that tracheal intubation in the ICU is very high risk. I've seen residents do this carelessly, not planning well. And what do you see? The patient suffers a cardiac arrest, maybe during intubation, immediately after intubation. So this is something we must take seriously. It's not something to joke with at all. And it must be done by somebody experienced in doing this. For dynamically unstable patients, you want to put a tube. Airway is threatened, though patient does not, maybe a patient with facial burns, for example. You want to intubate early enough to prevent obstruction of the airway following edema. Then in respiratory failure, most of the time you have no choice. You have to put a tube for this patient. Now, in intubating patient, as I said, preparation is a very important technique that you have to prepare for. You have to prepare, gather your team. Don't just rush to intubate, gather your team together, the nurses and all those. I'm going to show a schematic diagram on how the number of people or the type of grouping that you can use when you want to intubate a patient shortly. Positioning of the patient is important, and monitoring. So I'm going to go through this. Let's look at them. So team assembly and briefing. During that time, you need to, there's a pre-intubation checklist that was published by Difficulty Airway Society. I'm going to show you shortly. So you can go through that and see that everything is ready before you go ahead to intubate this patient, so that it won't be when you need those things, or facility that you discover they're not available. Then all those with you, you must define the roles of each person. The person is going to intubate, the person is going to give medication, the person is going to provide critical pressure, the person is going to record and time, all sorts. Then you must have strategy for plan A, B, C, and D. So as I said, most of us, we just go ahead and intubate without any subsequent plans. What if your initial plan fails? What are you going to do? And if that fails, what are you going to do? So you must have plan after plan. Then pre-oxygenation can go on simultaneously while you are doing the team assembly and briefing. So this is the intubation checklist by the DAS and the Intensive Care Society. So you can have this actually pasted on the wall of the ICU. So you can check everything before you go ahead to intubate your patient. This includes, there are about 4 sections here: preparing the patient, okay, preparing the equipment, preparing the team, and also preparing for difficulty. So these are important things you need to look at before you go ahead and intubate this patient. So this is actually very, very important, because you will discover that this has covered most of the things you are likely to need. You don't have to, your ICU doesn't have to have all these equipment and things, but at least look at those things that are basic, that are available in your ICU, and make sure you arrange them to be available when you are ready to intubate your patient. Sorry. Okay. So this is the composition and roles of the intubating team. Okay, so you can have a 6-member intubating team. If only one intubator and then the second intubator role is not applicable. Okay, so for example, you have the first intubator. The second intubator might just be standby. If the person fails or for one reason or the other cannot continue, the other person can take over. You have the monitor here, you have the airway equipment, you have your drugs, you have your cricoid, and this person is going to, you have somebody here, somebody here, somebody here, somebody here, somebody here, somebody. So you have a runner and you have a leader. So this is a 6-member team. Okay, then you have the 5-member team where you have the intubator, first intubator. Here you don't have the second intubator. You have somebody managing drugs, managing drugs monitoring second, also will serve as second intubator. Then you have the cricoid, somebody going to provide cricoid pressure and take care of other equipment. You have your runner and leader. Then you have the 4-member. Here you have the first intubator. This person takes care of drug monitoring, also is a leader, and also is the second intubator. And you have the person giving critical pressure and the runner. So it depends on the number of people available to you. But what this is telling us is that you must prepare your team. Your team must be ready when it comes to intubation, intubating your patient in the ICU. Positioning the patient is also very important. Actually, if tolerable, you can sit the patient or tilt the patient's head up to 30 degrees. Okay, and then the head must be in the sniffing, the head and neck must be in the sniffing, the money hair position. Okay, sometimes you can actually do whole bed head up. Okay, for a patient with suspected spine that you cannot adjust the neck anyhow, you can just do the whole bed head up. That also can help. The ramping also can also help, especially in obese patients, okay, where you support the back of the head, the neck, and the back of the upper back, and you put the patient in such a way that the external auditory meatus levels with the sternal notch. This position has been found to be very helpful in actually getting a good laryngoscopy. So the position is so important, so we must know that. So don't just go ahead, you must position your patient appropriately. Monitors, all standard monitors should be available. As we know, the oximeter, the capnography, blood pressure, ECG, and heart rate should be monitored while doing all this. Oxygenation around, before, during, and after intubation is very, very important because our patients are very liable and vulnerable to hypoxemia. So in a patient who doesn't have respiratory failure, you can pre-oxygenate using tight-fitting face mask, giving 10 to 15 liters per minute of 100% oxygen for about 3 minutes. This can help to load the lungs with oxygen and the blood with oxygen. In hypoxemic patient, CPAP actually is beneficial. You give some CPAP before you want to intubate, before you are ready to intubate the patient. This has been found to improve oxygenation very well before you actually go ahead to intubate. Because we know the apnea time in this patient are quite reduced. Safe apnea time quite reduced. So because of that, it's important you deal with this aspect very well. Load the patient with enough oxygen before you attempt to intubate the patient. The CPAP actually helps to prevent absorption atelectasis as much as possible. Nasal oxygen can also be used pre or peri, intubation. You can put nasal catheter oxygen through nasal catheter into the patient's nasal passage. This can also help before or during intubation. High flow nasal oxygen also has been found to be very useful, but this is contraindicated in patients with suspected base of skull fracture and facial trauma because of risk of translocation of bacteria into the brain. So let's go on. Now, during intubation, not just before, not just pre-oxygenation, during intubation, it's important you find a way to actually continue to improve oxygenation of the patient, okay? Because with the onset of apnea and blockade, alveolar de-recruitment occurs, and so you need to further improve patient oxygenation by delivering oxygen by the best formula available to you. You can use standard NASA or buccal cannula. In a study that we did in UCH Badon, we actually put nasopharyngeal catheter. Okay, that was how we were giving oxygen, and we compared that to other means like the NASA, and we found that nasopharyngeal catheter, giving oxygen through nasopharyngeal catheter, the tip of the catheter stays in the nasopharynx compared to the one that stays in the nasal cavity, improve oxygenation during intubation. So if you have high flow NASA and high flow oxygen, you can actually do that. You can do that as well, but I know most of the centers, we don't have this. But if you have, you can use it. But if you don't, the nasopharyngeal catheter and oxygen through the nasopharyngeal catheter actually has been very helpful, okay? So let's go on. Now, induction proper. This patient, most of the time, they are at risk of aspiration, because especially if you have to do emergency intubation. So it's important, some of them or most of them, even they have full stomach. So the rapid sequence is appropriate, but modified in the sense that you have to be gentle with your induction agent. Sometimes you don't bang it in as you do normally for for a patient you want to anesthetize. You have to give it gradually so that you don't worsen the patient's hemodynamic status. Okay, and to reduce the risk of aspiration, it's better you discontinue feeding like 2 to 3 hours before you attempt. That's if you have the time before you intubate the patient. Okay, then in fact, you might need to, if the patient is having real meal, you might need to observe a longer period, up to 6 hours. Okay, so to be sure that the patient will not aspirate at the time you're intubating the patient. So sometimes, if you have the time, you can actually remove gastric content by suctioning, because if it's an emergency and you have this, you can do that. Okay. Sometimes patient has NG tube and you want to remove before you intubate. Studies have shown that that does not really compromise the protection offered by critical pressure. So you can leave the NG tube in place, just provide your critical pressure, and go ahead and intubate the patient. How about the choice of induction agent? Ketamine actually has been favored. More so, ketamine with propofol is also favored as well. But in the hemodynamically stable patient, you can actually consider propofol. Remember, the challenge in this patient is that they have hemodynamic instability. So you want to use agent that will be as stable as possible. Etomidate, we all know, has its issues. So it's not something you want to consider this patient. This is another thing we must also know how to do and do well. That is providing hemodynamic support during intubation in critically ill patient. We don't really do this routinely in a patient in theater. But in the ICU patient, nearly half of this patient will develop hypotension following intubation. And this is because of the induction agent and the positive pressure ventilation you are given. So you can fluid load the patient or give suppressors to prevent or treat hypotension. You can do this preemptive give preemptive fluid loading and some vasopressor. Though studies have not shown that preemptive use of vasopressor actually reduce the incidence of the reduce mortality. Sorry, does not reduce mortality. Okay, but you should be ready with your vasopressor. You can consider fluid loading before you intubate the patient. Okay, so it's part of the bundle to fluid load patient. So you must know that in the ICU, you must, but this must be individualized, okay? If you have a patient in failure that giving too much fluid, cardiac failure, giving too much fluid can actually worsen patient's condition, then you must decide whether you need to just give small volume or give colloid. So you must individualize. But the important thing we are trying to say here is that you must have in mind that the patient, there can be cardiovascular collapse after you intubate the patient. So, as I said, prophylactic use of vasopressor instead of fluid loading to prevent hypotension may be an alternative, but as I said, it's not been found to improve mortality. So, but you can, the important thing is just get your vasopressor ready as much as possible. The neuromuscular blocking agent, rocuronium is actually favored here because of the complications following the use of succinylcholine. But I know in most of our centers in Nigeria, rocuronium is not available. So we still end up using succinylcholine. But just bear in mind that this patient must not be hyperkalemic. Okay, that's one thing you must be sure of. Potassium of the patient, you must watch it before you use Soxa in this group of patients. Or maybe you have a patient who has a spinal C-spine injury and the risk of proliferation of extrajuxtinal acetylcholine receptors is present. Maybe any patient with neuromuscular problem, usually some of them may end up, developing serious hyperkalemia. But if you have rocuronium, is good, okay? Studies have shown that the incidence of and severity of oxygen desaturation, quality of intubation condition, and incidence of failed intubation attempt did not differ between the two, okay? But the complication is just the side effect and adverse effect of Soxa is actually what you are afraid of. Okay, so time is important. Somebody is in charge of noting the time. Allocate a team member to know the time because you won't know that you spend so much time while battling with the airway. So this is so important. The nurse actually very good with that. So let one of the nurses keep time and let you know, the number of minutes you have spent after each attempt, okay, so that you can actually decide on what to do appropriately. Laryngoscopy, the goal is to achieve atraumatic tracheal intubation using minimum number of attempts. Repeated attempt, we all know that is going to lead to a trauma, airway deterioration, and can get to CICO or CVCI, that is can't ventilate, can't intubate condition. So you must, and that's why it's important that before you go ahead, or in the ICU, get somebody who is more experienced than you when you want to approach the airway in the ICU. So that ideally you shouldn't go more than 3 attempts. In fact, you don't have to go all the 3 attempts. If you know after the first attempt you're unable to intubate this patient, let somebody more experienced take over from you. So requirement for successful intubation includes you must position the patient well pre-oxygenated, and also oxygen given at intubation. You must anesthetize the patient, either local or general. If you are, for example, you are using fiber optic, you might just anesthetize the airway of the patient. Then the patient must be relaxed, except in awake intubation where you are not giving a muscular blocker. Okay, these are successful. These are factors that you want to consider to actually achieve a safe, successful intubation. So for the person intubating, you must have a plan. As I said, have a primary plan and a plan for failure. You must be somebody trained and proficient in all techniques as intended to use. So if you are somebody who are not conversant, you are not used to video laryngoscope, it is not at this time you want to try it. So it must be something you are familiar with. You must be supported by a trained and brief team. You must have a team, okay, with you. Then if one attempt fails, as I said, you must ensure that fauna is immediately available. That is, front of the neck asset set is available if one attempt fails. I know we don't do this routinely, but this is something we must do because if subsequent attempt fails, the patient will end up having front of the neck access, and you must be able to provide that. So you must also get help. Help must be available even before you start, not after you have failed. So let's note that. So after a failed intubation attempt, you can employ maneuvers to improve laryngoscopy, or ease of intubation. I'll just mention this when I look at the algorithm. So if all relevant factors have been addressed, the patient is very relaxed, the position is okay, and optimal intubation fails, don't make any further attempt, okay? As I said, you don't have to do all the 3 attempts before you raise your hands. No, if you have done all you need to do, and after the second attempt, you think you are not successful, then you need help. Failure after a maximum of 3 attempts should prompt declaration of this is a failed intubation. Don't keep on and just don't push on and push on and push on until patient desaturates and suffers a cardiac arrest. So you move to plan B, C. A 4th attempt will be considered by an expert if necessary before going for uh, front of neck access. So as for video laryngoscope, there are conflicting evidences about this. The important thing is that it should be available and considered as an option for intubations in the ICU. It should be available, okay? And it's not necessarily, those studies have shown that it helps with first attempt at intubation. But as I said, if you are not conversant with it, don't bother yourself. Just go ahead with your dial laryngoscopy, okay? So if a difficult laryngoscopy is predicted with the Macoca score, if it's greater than 3 or equal to 3, then you must consider video laryngoscopy from the outset, okay? So if you have a pure view with dial laryngoscopy, subsequent attempt also a laryngoscopy should be with video laryngoscopy. So it has its own roles in the ICU, but it does not, it will not completely knock off dial laryngoscopy, especially if you are not somebody who is conversant with the use of video laryngoscopy, okay? So this is the algorithm by the DAS and Intensive Care Society. It's a bit old, but it's still very, very valid. So you can look at that. It's essentially what I've said, okay? So laryngoscopy maximum of 3 attempts, confirm. If it fails, then call for help, okay? Video laryngoscope or front of neck access. Now, if after 3 attempts, you have to declare failed intubation and you ensure oxygenation is maintained, then you go on to second generation spaghetti airway, face mask. So you go, all these are to ensure oxygenation. At this point, you want to just ensure oxygenation as much as possible and think of what to do. You want to wake up patient, you want to wait for an expert, or you want to intubate through a spaghetti airway or do fauna, okay? So when all this fails you, then you go to fauna. Let's go on, our time is up. Let's go on. So for CICO or CVCI, the can't intubate, can't oxygenate, then you have no choice, you have to go for fauna. So every one of us should be able to understand and know how to do this. This should actually should be completed in about 15 seconds. So before you do this, extend the neck, ensure the patient is very relaxed, continue rescue oxygenation, and exclude oxygen failure or block cycle. You must be sure the oxygen is actually being delivered. So the scalpel cricotiotomy comes very handy, okay? And you just need the scalpel, the bougie, and the tube, okay? And it's for palpable. So you remember I said that before you even touch the patient, you must have examined the neck to check the access for fauna. So for palpable cricothyroid membrane, you just follow this, okay? You can read this. Let me go on. We have many other things to talk about. So that's the algorithm for can't intubate, can't oxygenate, or CVCI. So for post-intubation care, after you've successfully intubated the patient, you must initiate, usually in the ICU, initiate mechanical ventilation if required, using appropriate sedation. You must document, we don't routinely do this, and it's important we do it. Document the exact marking of the trachea tube at the level of the incisor or the nose. And that must be checked from time to time, okay, by the nurses as they take their shift. So the trachea tube position must be noted by the nurses so that it could have migrated inside or outside. So that is so important. Then ideally, you're supposed to do a chest X-ray after intubation to know to confirm the position of the tube and to check the nasogastric tube position. Okay, this is something that is, most ICUs in developed places have a portable X-ray. So just after intubation is routine. You don't need to even tell anybody. It's routine. They just do the X-ray and see your tube and see where it is. So that gives you some confidence that, okay, your tube is actually, the length is okay and it's actually well placed. So you can only start feeding if you have done that confirmation. That is the teaching. So if you have not done the confirmation, you are not supposed to start feeding. And the cuff pressure, the tracheal cuff pressure should also be checked from time to time. Ideally, you want to keep it between 20 and 30. So this should be checked during each shift too, so that you want to be sure that the cuff is intact. It shouldn't be too tight and shouldn't be too loose so that you won't cause necrosis of the mucosa. And if it's too loose, you may actually end up with aspiration. So you must maintain the patency of the tube. by regular suctioning as much as possible. Studies have not shown that the closed suction system is better, but I think if you can afford it, your patient can afford it, a closed suctioning system is better. From my own experience, it reduces the risk of chest infection, okay? Because in most ICUs, patients are not able to afford the proper suctioning, because ideally, once you put a tube in the airway, that tube should be discarded. That is the practice. But how many patients will be able to afford that? Unfortunately, the closed suction device that can be used for 48 to 72 hours too is not cheap. I mean, one is about, is it 40,000 or so? One, and you can only use it for about 2 to 3 days. But I think if you can afford it, if a patient can afford it, that seems better to me. Now, these are things you should note in the ICU for this patient that you have intubated. If you have absence or change of capnograph waveform with ventilation, then there's a problem. Okay, maybe there's a dislodgement. If there's absence or change of chest wall movement with ventilation, you have to check your tube. If there's increasing airway pressure, so keep, your alarm on the ventilator, you must set them so that if you have increasing airway pressure, there's a problem. The tube will be blocked, okay? Then if there's reducing expiratory tidal volume, then that means that there could be leak. Maybe your cough has gone down or something has happened, okay? If you have inability to pass a suction catheter, if you are suctioning per time, then that also can be a pointer to problem. There's obvious air leak, apparent deflation, or need to inflate over time, need to reflate from time to time, inflate the balloon that maybe you have to change it to. If there's discrepancy between the actual or recorded tube insertion depth, then maybe your tube is going in or coming out, so you have to note that. Now, extubation in the ICU is also so you don't just intubate the patient and you don't plan extubation. The extubation, in fact, sometimes you lose the patient at this period, not even at intubation. And extubation can be planned or unplanned in the ICU. And in the ICU, you must anticipate reintubation. Whether you've done a planned extubation or unplanned extubation, you must anticipate a reintubation, okay? And this can be because of airway edema, or patient can just deteriorate suddenly, okay? So for planned extubation, studies have shown about 50% of patients extubated in the ICU may actually require a reintubation within 48 hours, okay? So extubation should therefore be considered a trial with the possibility of reintubation. So I'm sure we're comfortable with the fact that when you're extubating the patient, you actually prepare to reintubate that same patient. So don't extubate the patient without being ready to reintubate. So elective intubation of non-difficult airway should only be performed in daytime hours. In fact, not only difficult airway, but as much as possible, extubate your patient during daytime. I think that is safer. Then, if you're extubating your patient, you can actually consider doing that over airway exchange catheters or over a fibrinotic bronchoscope, because that can, if you have extubated the patient, for example, and you suddenly have to intubate again, if you have extubated over airway catheter or fibrinotic bronchoscope, you can actually observe the patient and see whether you need to put the tube back or not. So if you have to put the tube back, these devices will actually act as a guide for you to actually put your tube back without a little or no stress. After intubation, if you can provide CPAP or NIV or high-flow nasal oxygen to your patient, studies have shown that this actually can reduce intubation rate, re-intubation rate in our patient. I know what we do is just to put a non-breathing face mask or normal face mask to just deliver oxygen. But if you have these devices, you can actually make use of them, especially in the ICU, to actually improve or reduce the risk of re-intubation in our patient. It just helps to, reduce the collapse of the, especially the CPAP and the NIV, help to reduce the collapse of the airways, okay, in immediate extubation, immediate period after extubation. Post-extubation stridor can occur, especially in patient that has been intubated for a prolonged period. Usually, I don't leave a tube in place for longer than 10 days, okay? 7 to 10 days, okay? After that, you must consider changing the airway device. I mean, most likely you want to progress to tracheostomy because of the risk of stridor. Okay, some people have said before you extubate, you can actually give some steroid. Yeah, I do that as well, but evidence does not support the routine use of steroid. And it's just, I mean, I think we do it and we get some results, but it's not something that is actually supported with so much evidence. For unplanned extubation, also this is common. What is important is early recognition. And if you are watching your patient is being monitored, well, you can actually determine or know when the unplanned extubation happened. And you don't need to panic at this point. One important thing to do is to maintain oxygenation. And you can do it by just applying face mask, either non-rebreathing face mask, NIV, I mean, whatever you can give, just give some form of oxygen. At the same time, you are preparing to re-intubate, okay, and then you cannot intubate the patient immediately after, okay? So, but this is something we must look out for in the ICU. As I said, some of our patients will end up with tracheostomy. I mean, and about 10 to 15% of them can end up with tracheostomy in the ICU. This can be provided either percutaneously or surgically. In most of ICUs, we still do surgical tracheostomy, but the ideal thing for the ICU is actually percutaneous, which can be done by the intensive care physicians themselves. And morbidity is actually better. But the truth is that once you have put a percutaneous tracheostomy, patient will eventually end up with a proper tracheostomy. Maybe percutaneous because you can do it on emergency basis. Surgical, on emergency basis is actually quite challenging. Sometimes you can even lose the patient when the surgeon is doing a tracheostomy. What are the indications for tracheostomy? We all know prolonged mechanical ventilation, relief of airway obstruction, facilitation of pulmonary toileting, weaning the patient, and allows to also reduce sedation. It helps to improve patient safety, give comfort, and reduce the overall cost of care. Before I end, I will just quickly mention human factors in airway management. This is very important. Because of the complexity and challenges involved in management of the airway in our ICU patient, we need to consider human factors because sometimes we are so overloaded with work, a lot of burnout, a lot of stress, and this guy that has been in the ICU for hours, and maybe in early hours of the day, the patient just coughed out the tube, and the guy is so tired, the doctor is so tired. So a lot of, makes it difficult for him to appropriately judge and manage situations at times. So there's cognitive overload, there's lots of situational awareness, fixations, errors. Somebody is doing the wrong thing and he keeps on doing the wrong thing because he's just fixated. He's tired, he can't think at that time. So he's not able to make proper decision. And because of this, people have suggested that actually NAP4 reports reported that about 40% of adverse outcome actually happen because of human factors. And so because of this cognitive overload, people have suggested that cognitive aids may actually help in the ICU especially, and it's said to improve technical performance and team communication in crisis situation. And one of the common ones that have been advocated is Vortex approach. It's one of such cognitive aid developed to support decision-making in the ICU. And the Vortex is just a pictorial view of what you can do when you have issues with airway difficulty in the ICU. It gives you a diagram of a safe. For example, this green is talking about a safe area where everything is still fine. Now you approach, once you go to this, now it's like, it's a vortex. So it's something that spirals and spirals until you get to this point, okay? So at this point, you are trying to maintain the airway. Maybe you started with the face mask. So everybody is seeing this, and you can actually use it as a guide to manage the airway when you're having difficulty. Okay, this is a face mask. You started with that. Then maybe you try to intubate, is not successful. At each of these, when you have difficulty with intubation, for example, you can try each of these devices 3 times to maximize oxygenation. You try your face mask, you ventilate, it's not doing. You do laryngoscopy, you want to intubate, it's not going. Remember, we said it's only 3 attempts, so you can't go more than 3 attempts with intubation. That is not successful. You go on to LMA. You try LMA now, also 3 times. And as you do this, remember the patient is spiraling. Okay, you started with patient is fine at this point. You go to this place, patient's saturation is still a bit stable, but it's going down gradually. You get to a point where the patient saturation is actually very precarious. Maybe patient saturation now gets to like 75, 80. Oh, then you have to consider front of the neck. This is suggesting or is depicting front of the neck access. At this point, the saturation is very poor. So you do front of the neck access, you go back, you're able to go back to the green position again. That is, you're able to get patient's airway, assess patient's airway. So this is just something that can guide you. You can look at it and see, have I actually attempted to use the oropharyngeal airway, have I attempted to use it up to 3 times to maximize oxygenation? Have I tried to intubate? Have I used LMA? So all these are things that just point you to what you can do when you're having difficulty with intubating this patient. This does not apply only to the ICU though. Actually, it can also apply to any emergency situation that you find yourself when it comes to airway management. Now, in conclusion or in summary, we can look at this. This is the recommendation by the NAP4 when it comes to best practice recommendation for airway management in the ICU. I've actually talked about most of them, but you can review them later. So in conclusion, in the ICU, when it comes to airway management, regular training is so important. You need to do regular simulation and get yourself prepared because you never know when you get into this trouble with the airway. So you must be able to get familiar with most of the equipment, locally available equipment. You must be familiar with the checklists and algorithms that are available. And teamwork is so important. You must work as a team when it comes to the ICU and especially when it comes to airway management. So airway simulation should be performed regularly and it should involve all grades of staff, not just the doctors, the nurses, even the maids, because they might have 1 or 2 roles to play when it comes to airway management in the ICU. Handovers should be routinely shared. That is, when you are handing over a patient to the next doctor, you must give information about the airway to the next person taking over. This will allow the patient the person taking over to know what to prepare for as per the airway of the patient. Future research is important. We look at ways to intervene so that we can mitigate the incidence of cardiorespiratory complications during tracheal intubation. This is a major problem. So our centers can look at how do we use our suppressor, or what other measures can we put in place so that we can actually prevent these cardiorespiratory complications at intubation. Then we can also look at interventions aimed at increasing first pass tracheal intubation. What techniques can we employ so that our first pass tracheal intubation can actually be excellent? Then the role of video laryngoscopy in the ICU, we still need to continue to explore that. So I want to acknowledge Dr. Segun Olusola in UK, who provided some of the materials I used, and Professor Sheila Mahentra in India. She actually gave me a paper she published on considerations of the airway, concentration when it comes to airway management in the critically ill patient. So these are my references. Thank you for listening. Do have a great day. So I'll be able to take your questions if you have them. Thank you very much.